Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for February 21st, 2018. Thank you for joining us for our presentation this month. Our presenter today is Dr. Heather K. Vincent. She is the director of the Human Performance Laboratory and the director of the University of Florida Health Sports Performance Center. Her main research focus is the study of the effects of obesity on joint disease mechanisms such as osteoarthritis and the development of exercise-based interventions to reduce disease pathology, pain, and disability. So welcome, Dr. Vincent.
Thank you so much. I really appreciate being asked to come talk today, and I appreciate everyone tuning in on their lunch hour and joining me for this discussion. What I'd like to do today as we go forward is take a slightly different approach from maybe some of the discussions you've heard in the past and talk about that complex group of people who are young, heavy, and starting to develop the early symptoms of osteoarthritis, and that's manifested by pain. So what can we do? What are ways that we can approach this issue of pain and get these people thinking about pain as an early signal that maybe they should get moving and incorporate physical activity? So the purposes for today will be very briefly first to understand the relationship between obesity, physical activity, and joint pain itself. And then second, maybe to provide some specific methods to help children and families who are dealing with weight challenges start to overcome pain symptoms by incorporating exercise. So one of the first things I wanted to mention is that those of you who are out there, if we have any pediatric providers out there, we know that they are more likely at this point in time to be seeing children who are overweight and obese than children who are not. And these children often come in sedentary behavior, have lower functional ability, relatively less muscle strength and endurance. This means that when they do engage in physical activity, it can be pretty unpleasant. And so they often will indicate that exercise is fatiguing, it causes windedness, and it's very uncomfortable. And more often than not, this contributes to activity aversion. What can make things worse is the presence of pain, whether it's in the ankles, feet, knee, low back. This presence of chronic pain is now developing earlier in the younger demographic, and it's actually becoming an emerging health crisis. In addition to the body weight issues, pain is now becoming a more prevalent issue in the same population. This is not just problematic for younger years, but if we look at the impact of what happens if this weight is not addressed earlier, is that, for example, one of the big epidemiologic studies that tracked what happens in overweight children from 1985 forward is that just being an indicator of childhood overweight, that alone predicts knee pain and dysfunction in adult men. Another study indicated that just simply carrying over body fat, doing nothing about changing body habitus from younger age into adulthood actually increases the relative risk of having knee pain while walking up to 2.4. And another example is that simply by being overweight at the age of 14 years during adolescence is going to be a significant predictor for multi-site pain in young adulthood. So we're not talking about an issue that occurs just decades down the road. We're talking about imminent issues that can impact quality of life in early adulthood. And so a time of high risk for musculoskeletal pain to develop occurs actually in adolescence. And this is largely because we have a lot of major life changes that are occurring, including a lot more independence over self and self-activities, increased awareness of self, and social pressures that change from elementary school into middle school, but also there's a lot of emotional stress that's developing. And when you combine that with changes in participation in physical activity, more so a withdrawal of the amount of physical action that's taken, psychiatric disturbances can develop. So there has been an increase in anxiety and depression, which are also directly related to joint pain. So there's a combination of factors here that are contributing to this problem. The common sites where we typically tend to see this include the low back, which depending on the study cohort can range anywhere from 4 to 40%. And then for multiple pain sites, some studies report prevalence as low as 4%, others nearly 50% in children who are obese or overweight. If we look at what this means by changes in body weight during youth, we see that for every increase in 10 kilograms of body weight, the odds risk of developing joint pain also goes up by 10%. So these are on the load-bearing joints that are highlighted in this picture, largely low back, knees, and ankles. This type of pain appears to be most prevalently reported among girls. Whether or not this is an issue of greater parental reporting for daughters than sons, there's been some evidence to suggest that. But what we know right now is that pain appears to be more common in obese girls than boys, almost 60% versus 40%. So why might this be happening? And I just wanted to take a couple minutes of time and share with you mechanically why overweight can lead to joint pain. So first, we know from a systemic perspective that adipose tissue contributes to chronic inflammation. So when we have chronic inflammation that adds to the mechanical loading, pain starts to develop. So this is a picture of a 3-year-old, a little toddler right here, who's actually already demonstrating the key signs that we might be looking at from the orthopedic perspective on foot joint misalignment and loading. So even children this young are already showing signs that can contribute to ankle osteoarthritis. For example, what happens is we have the ankle turning in with greater abduction of the calcaneus, greater plantar flexion, and we also have greater dorsiflexion of the midfoot, which means a lot of that weight is now going to be stressing the ligaments of the arch of the foot or the talotibial joint, and that can contribute to pain. The knee is also a prime site for pain, and there's a couple different ways that obesity contributes to this. It can be due to patellofemoral tracking or to the application of abnormal forces onto the tibiofemoral joint. So if we look first at the patellofemoral pain, what can be happening is that in sedentary obese children, there is a relative mismatch of strengthening on the lower extremity muscles, which can cause or contribute to the maltracking of the patella on the femur. And after a while, what tends to happen is that there's a grinding of the patella, which ends up hurting. So when we strengthen and work on appropriate exercises, we can actually correct that. So physical activity can help. Secondly, the knee is a very interesting joint in that it funnels and amplifies the pressure that's put on it. So for every pound of body weight, it actually amplifies the loading 4 to 6 pounds through each individual knee joint. So you can imagine that even in overweight children, pain is going to start to develop. And then finally, another common area is the low back with chronic diffuse pain. And largely what's going on here is that if we look at the normal healthy spine, we see a beautiful S-shaped curve that it is now adjusted and put in an aberrant configuration when we apply a lot of weight to the front, as in a large abdominal girth. We are pulling on the vertebrae in an abnormal way and causing spine lordosis. And these muscles that are now trying to attempt to hold the spine in appropriate posture are now strained and become easily fatigued, all of which contribute to pain. So if we look at the general pathway of what's going on here, a lot of these things can be modified by physical activity and worsened by sedentary behavior. Now, if we look at the relationship between what happens between parents and children with respect to BMI, with younger children who are heavier, the parent pain catastrophizing levels actually increase. So this is kind of an interesting phenomenon, where if we look at parents who have heavier children, what they attempt to do is try and protect the child by restricting movement and keeping them out of physical activity. So it's the parent distress in some cases that mediates whether the child participates or not. What often happens here is that the parents seem to be more anxious about pain reported in girls, and so they might be more likely to report that as physical disability. So it's an interesting pattern that's emerging, that it's not the parent who's being helpful in this point, they're actually pulling back on physical activity and actually making the problem worse. If we also look at the parent thought process on child activity relative to weight, what can happen is that in some cases that if the child is heavy, they believe that the child may not be ready to participate in exercise and hence don't. The children, however, think about physical activity and their associated levels with pain and discomfort. So there's a disjunct in how physical activity is viewed by parents and children. So it's very important that we help children overcome a little bit of this fear of pain and discomfort and get them physically moving. This is actually a picture right here. I promise it's not a child being tortured. It's actually a child in one of the weight loss and weight management programs in China. Where obesity has become such a huge problem, there are multi-week programs there that parents will send their overweight child to, and they have balanced nutrition that's supervised by professionals, and they are very active throughout the day. So this is simply a picture of a child who doesn't like the discomfort of physical activity, and you can see in the background other children exercising, and the supervisors of the program who are coming over giving the child a little massage and checking in. But this is a prime example of when you're unfamiliar with the aches and pains and discomforts of physical activity and you're heavy and you're not used to it, it can be unpleasant. So we need to start thinking about how to engage kids earlier before it becomes such a problem. So when we approach children and parents, some things to think about are families often think of pain as a bad thing. But I'd like to propose an alternative that pain actually signals the need for change. And it's telling the body that something is not right and we need to get moving. Now, pain without injury during movement is expected, and we need to move through that. So what do I mean by pain that's expected versus not? We're talking more about muscle soreness, a little bit of that burning sensation, but that's transient and it goes away, and as the body adapts, it will get better. So we need to inform patients and families about that process. We also need to listen and acknowledge and identify goals and preferences of the family and the concern so that we can move forward in a positive manner. So here, the first step is to listen to the parents who might be coming forward with an obese or overweight child. So some ways to approach this are first to say, if I understand you correctly, you're worried about Anna's knee pain. And from what we know, the knees carry a lot of weight, but when they carry more than when they're designed to, they're going to get irritated and ache. That way you've acknowledged the parent concern, but you've also indicated that there's going to be a long-term problem if it's not addressed in a non-threatening way. Secondly, you could approach it as, I hear you, I understand that it's worrisome to see your child in pain, and I can appreciate the last thing you want to do is your child might want to do is actually move on the joints. But a positive thing is that movement can actually help achy joints in many ways. So again, you've connected with the family, you've connected with the child, addressed that there is a concern and you hear them, but we can move forward positively by incorporating physical activity. So sometimes it's just about setting the tone to get started. So being realistic and setting an agenda with them that it's going to take time, and that exploring options for them in terms of time, resources, travel support, what types of blocks of time can we use, and that exercise for the child is going to feel challenging at first and may initially make you feel sweaty and a little bit winded and have some pain and discomfort. We can also reassure them that even highly trained people experience some of these same things because their body is adapting. So this is not a bad thing, it's the body trying to get better and heal itself. Also addressing with the family that this requires consistency, and this is often a long-term barrier to success for a lot of the patients that end up dropping off. So consistency is going to be a big key in managing joint pain. So one of the ways that we've accomplished this here is to start with small goals and to journal it down and record what it feels like. So this doesn't have to be fancy, but having a child write in a notebook what they did, what activity that they like to do, and how they felt is going to be very important. And rather than focusing on weight change at this point, we are focused now on joint pain and getting them to feel better. So I want to make sure that that's clear as we go forward, that the focus is on correcting joint pain and getting them engaged in activity. So in this case, we want them to identify how it makes them feel during exercise and after, and whether or not, even during exercise, the pain got better. And hopefully, if all goes well, it should get better. We also want to know what happens with the physical capability over time. So the emphasis at the start of the program should be, what can you do now that you couldn't do before? So for kids who are very heavy, that have very relatively low strength, we want to focus on, for example, maybe working on doing 10 squats appropriately with no weight. Can they do it 10 times? And if they initially have a little bit of pain, does that pain go away? And then the following week, can they do 15 to 20? How does that feel? You could do the same thing with a modified push-up, something where they're engaging whole body exercise and moving all major joints is going to be very important. but emphasizing physical ability and how it makes them feel. You can also provide some reassurance here along with evidence in a way that's pretty interesting. So this is also a picture of one of the programs in China that shows the kids actually running on a track. And they're clearly exerting themselves as hard as they can. So I enjoy this picture because these are the kids that are now moving toward that phase of enjoyment of exercise. And that is that even acute bouts of maximal aerobic exercise can help with joint hypoalgesia, which is a great thing to let people know that it might ache a little bit at first, but as you move more, it should feel better. Very similar to what we see in adults who have osteoarthritis. With children, we expect it to be a more profound response because they're much earlier in the process. So that exercise can both benefit weight and improve pain symptoms. Another trick that you could use to help these children engage into exercise is using graded exposure. So that is first in the initial evaluations and working with children is to first find what their physical limits are. So we determine the tolerance, whether it's through a walking test or a functional battery of testing or something that they're interested in, whether it's bicycling or doing weights, something that might be relevant to them, find what the tolerance is, and then step back and set a quota. So if we know what the maximum is, we pull way back and we work on maybe trying, can we achieve 33% of that or 40% of that during initial stages of exercise days? And then if they get better, can we push that by a couple repetitions or 30 seconds longer the next time? But the point is you're allowing the child to help set those quotas, which can be a lot of fun for them to beat their goals. So graded exposure is this idea of taking an activity and at first having them get started on intensities that don't trigger this fear of joint pain. And over time, what you do is you up the ante by increasing the distance, the duration, the exposure, until it does trigger a little bit of that fear where, oop, I feel the joint pain kicking in. Okay, we're going to move through this. Let's keep going another 30 seconds and show that they can do it and that they can finish. And it's going to be okay, and the pain diminishes after the exercise. So when all is done well, you get them over that hump of being fearful of the discomfort. And so what's also going to be important for them to recognize, the child and the family, is what is pain that's expected versus unexpected or unwanted pain. So be very clear that when you talk to children that they are probably going to have a little bit of initial joint aching at the start of exercise, may initially feel kind of dull, and maybe sort of diminish a little bit during exercise, and they might have a little bit of muscle soreness that 12 up to 48 hours, maybe a little bit longer, and that is going to be expected. But unwanted pain are the following, and this is going to be critical to help determine whether or not the workload was too high for that child at that time. If there's any sort of acute increase in sharp pain, or if it increases to more than a 4 out of 10 points on a 10-point scale. So let's say they have a mild ache of a 2 out of 10 points, and they exercise, and now it shoots up to a 6. That's not something that we want to do. That intensity might be too high or the workload's too high. If you see that during the movement there's some sort of a limp or a change in how they're moving, that also is too stressful. And finally, any sort of pain that lingers out to 24 hours that remains pretty high indicates that that is too much on the joints, and we need to back off a little bit in terms of intensity and start a little bit slower. So discriminating between expected and unwanted pain is going to be very important. So the progression as we go forward, as we synopsize the evidence, this appears to be a sensible progression in going forward first with developing strength and coordination, moving joints, and using the graded exposure approach. As they start to get a little bit comfortable a few weeks in, then we can start incorporating more aerobic activity that might be a little bit more energetic. So moving from a walking to a brisk walking to a jog weeks in might be helpful, and then increasing the intensity so we're doing more interval bouts if the joint pain has really diminished or gone away. Hopefully at this point, as we move forward months along into the program, they might be ready to participate in more of an organized physical activity approach. So not jumping into organized physical activity and maybe making them uncomfortable right away and having the option of them failing. We want to do more of a progressive and graded approach toward getting a handle on this joint pain. So the supported resistance exercise appears to be a safe way to go as long as it's supervised by appropriate professionals for children 17 to 13 years of age. And what we're trying to do here is allow them to get confident and competent and to experience less discomfort when they approach the aerobic exercise now that they're more accustomed to dealing with the loading. We also want to work on an appropriate technique at this point here and get kids to start enjoying what it feels like to meet goals. So what type of equipment is appropriate here for kids with joint pain? We want to start with largely supported machines here with either weight stacks or pulleys, and an example is shown here in this image of the child that's sitting on a machine really working some upper body strengthening activity. And the idea is ultimately we want to progress the child away from all machines and then start ultimately doing some light free weights that are done in a controlled manner under supervision. So these are some sample exercises that hit all the major joints, but being particularly sure we would like to get the ones of the lower body as those are the load-bearing joints. Upper body is also important, obviously, for physical function, but we want to make sure that we're really stimulating the joints that are going to be bearing the brunt of the load as they move forward in their exercise program. Functional movements are also critical in developing confidence in children, and this also translates to a lot of movement and real-life activities. So here, functional strength and control of movement are going to be goals as well as easing the joints into more dynamic loading. So these types of balance and stability exercises that you see here give an idea of working on coordination and balance and a lot of functional control. So this could incorporate a plank type of a movement and a walking push-up, or it could involve a balanced core movement with support from upper body and core strengthening, and then developing lower body strength and coordination through lunges or squats or other full body activity. These are other exercises that can be used in children of all ages. While this picture actually has a young adult, I want to reinforce that this can be done in very young children, even with no weights. So learning to develop coordination on a twist maneuver, on a leaning forward lunge and a row-like motion. Also using rehabilitation balls for support can be a lot of fun for kids, as well as doing step-up type of activities. So mixing it up can also make the exercise a little bit more challenging and also is safe. We're not putting a child into a position where they're going to fall over and hurt themselves. The ball is low to the ground. The person is standing on the floor or simply using a step-up at varying heights. They can also use body weight-based exercises, and they can do these in the privacy of their own home. So if being out in public is a little bit more challenging for these kids, then you can set up a system such as this using ropes or cables or a TRX system to allow them to work on a lot of the strengthening in areas that are going to translate to functional activity. So these are also very good examples. We know for adults with osteoarthritis that walking outside at a brisk pace is very important. But what if you have a very obese child with joint pain and walking briskly is uncomfortable? Well, you can try indoor exercises on a treadmill with shorter bouts, so you can accumulate smaller bouts over time, and what that does is reduces the medial joint force on the knee. Or you can alternate and change the incline and walk at slower speeds, which will offset the compressive knee forces. So there's ways to get around this and get a child moving even if they have challenges with brisk walking. But we can also think beyond our basics of walking and running and explore options in the community. And I would welcome everyone to see what's out there as you make recommendations for the children that you're working with. For example, we see on the top left corner, these are, for example, chain programs that work a lot on martial arts, confidence building, balance, and strengthening. There are group classes that can even do gentle, low-impact movements such as Tai Chi or dance. Or there's even relatively low impact on trampoline-style exercise in various fitness avenues. So there's a lot of different ways that you can explore physical activity. What will also be very important is following up and engaging, and you can do this in a variety of ways, through e-health messages, through using electronic record options, and if you're a physician or as part of the care team, have prepared a set of questions that you would like to go over so that you can hold them accountable. So some of the questions that will really focus on the joint pain and physical activity include enjoyment, how did pain improve, how many times a week did you get to move, and do you feel stronger and more confident about yourself? And looking to see what the child logged in and how they were feeling, and is there anything new that you would like to try. So at this point, as we go forward, this allows the child and the family to contribute. So if things are not working, or the child did not engage or refuses to do, here's where we can try and solicit their input. If it's not working, let's change this up. What do you want to do? What do you want to try? And a classic example that I would like to give is that you could suggest something that is an activity but not an exercise plan. Now, this is not vigorous activity, but in an obese child who loved to talk on the phone with her friends and not get up and move, the goal was she could not sit down. She had to walk around the house as she was on her phone. So those are the little things that we try and do to keep the person moving and stimulating the joints. And as the pain improves, here's where we move more toward autonomy, increased activity and participation, and then moving toward organized sports to help them achieve the recommended levels. But we have to get control over the enjoyment and the pain itself. And so these are the types of options that are out there, even here in the Gainesville community, are, for example, youth combines or youth fitness classes where you can see if, after months to a year in and a child has lost a little bit of weight, perhaps this might be the time to introduce them to these types of activities. As I wrap up here, these are additional resources and options that you can check into that are free. And then finally, who should you turn to if you are trying to recommend families and patients for this type of training? So I would look for trainers with appropriate certification, and youth fitness is going to get you probably the safer options, whether it's through American College of Sports Medicine or the Idea Fitness or ACE Fitness. At least they'll have an idea of how to work with youth and families. So these are my final points for today. In helping to get children to manage joint pain is that we've got to build confidence, strength and balance, and then move toward the weight loss. Being sure that patients and families understand the difference between expected and unwanted pain, and then using different techniques to try and understand the personal goals of each child and family so that they can reach their goals. I'd love to answer any questions or comments that you may have. Thank you very much.
Thank you, Heather. Thank you, Dr. Vincent. That was a great presentation. I loved how you had the resources at the end as well for everyone. And just want to remind everyone to type in your questions in the chat box and we can get a discussion going. And I have a question just to start us off while we wait for some other questions to come in. When you explain the expected pain versus acute pain, how exactly do you go about explaining that to the children? Do you use pictures, or is it mostly just words and education around the differences between expected and unwanted pain?
Yes, and that's a very, very good question because kids can actually be pretty observant. So I might start the conversation with saying, as you initially start your movement and your activity, do you know what it feels like when you work really, really hard and you're running outside as hard as you can? Do you know what that feeling is? And most of the time they'll say yes. And I'll say, okay. So when you're done, your muscles might feel a little tired, a little bit sore. That's normal and that's expected. If you start to feel a sharp pain, like someone is poking you with a knife or with a pin in any of your joints and that pain gets worse, that we don't want to have that. That's not the kind of pain that's appropriate. So I try and give them something that's tangible that they can relate to. And most kids know what it feels like to run really, really hard and then be tired right after, or a little bit achy, a little bit sore. And most people know what it feels like to get poked or cut. So I kind of use that as dull pain versus the sharp, unexpected, and one that lingers on to the next day.
Great. Yeah, that's a great great way to explain it. Sharping and poking is definitely
Yeah,
very different.
yeah.
That's great. I also, um, I thought how you were talking about enjoyment and that kind of feeling you get after that. What's the name? Sorry, I don't know the scientific term.
Hypoalgesia?
Yeah, hypalgesia. There we go. I think that's really interesting that um, and key aspect of exercise because sometimes it's not very fun when you're going through it, but afterwards you pretty much always feel great. So the key is you have to
That,
get to that enjoyment, though.
that's exactly right. And I think probably all of us who are on this phone call right now, we all know that we have days that we don't want to exercise and we kind of push ourselves through it. That's normal. That's being human. For kids who aren't used to doing this type of exercise, the trick is just getting them up and getting them a little bit sweaty first, getting them moving, and then find out, hey, this really isn't so bad. The tricky part is that it will take a lot of parent involvement um, and kind of holding the child accountable for making sure that the activity gets done. And that might mean that the parent has to do that exercise with the child. So there are different ways that you can do that. And even in our own home, we have to be very creative with how we get our youngest up and moving. And so we try and make games out of it. And we kind of have a little bit of a quota as well. We say, nope, you can't sit there and do that unless we get a mile or two in of walking. This is what we need to be doing. And it takes an effort. It does take an effort, but when it's done, there really is that feeling that it's all right. My body feels good. I feel like I accomplished something. And those are the things that I try and emphasize with overweight children is how did it make you feel?
Great. And we have a few questions that have come in now, so I'm going to go ahead and read those.
Okay.
All right,
Okay.
so thank you for mentioning the contribution of pain catastrophizing behaviors of parents. It suggests that not only does the child need to be educated, but so too does the parent. Do you have any specific recommendations for managing, educating, intervening with parents of obese children?
That is a fantastic question, and I know that this is a very big deal. Even in our own musculoskeletal clinics upstairs, I'm sure it's the same issue in many of the orthopedic centers around the country. Part of what you have to do is have a very honest conversation that does involve having the parents, understand that yes, exercise may initially be a little bit painful, and just being right up front that pain is a way of telling the child's body that where they are right now is not a healthy place to be. But the pain doesn't mean that they're worsening the actual condition. It just means they're trying to adapt to it. So unless there's continued weight gain and they're not following through on their movement patterns, things are going to get worse. But if they make the attempt and have the child move and move through that pain, and yes, the child will probably say it aches a little bit, that's normal, that's to be expected. What we do want to tell the parents, though, is that we should see an improvement over time. If the aching does not get better and the weight does not improve, then we need to mix things up a little bit and maybe, think about other ways to. They should be thinking about diet as well. But in terms of physical activity, we can go so far with it, but then we also have to start thinking about the nutritional piece as well to get the weight to come off before engaging in a little bit more of vigorous exercise. So yes, there is that part of getting the parents involved, understanding that there's going to be an unpleasant period a little bit, and then moving toward progress as the pain starts to get better.
Yeah,
and one more thing. One more thing I want to mention is that sometimes parents will ask for pain medications where they do not want the child necessarily to engage in any sort of exercise program. They just want the pain to go away. And what we need to do is start changing this culture that giving a pain medication for musculoskeletal aches and pains in youth it's not okay. We need to be looking at other options for self-control, self-motivation, and becoming active in the child's health care. And that's not necessarily a popular message for parents, but it might alleviate some of the catastrophizing in a way where they will have a lot of control over this if they are working together with the child to make progress. This is a controllable issue.
Yeah, that's a great point that you make. I didn't realize that parents were reaching for that, but that makes sense because I think a lot of adults are also just reaching for that as well, the pain medication, I mean. Um,
That's exactly right. And when we think about medicine, we should be thinking about ability, becoming, an ability doctor and not a disability doctor. We want to promote movement and prevent osteoarthritis rather than just dulling the pain so they don't have to make any other movement or diet changes.
Great. And I'm going to ask, we have one more question in the chat box. I know we've gone over the time, so I just wanted to thank everyone for attending. If you need to sign off, you can, but we'll keep chatting as long as you guys keep uh, asking some questions and discussing. Um, so, next question. We've discussed how engaging teens, especially girls that are overweight in physical activity, is a challenge. A new study from Armstrong et al. Looked at using motivational interviewing strategies via text messaging as a way to reach and engage children in obesity treatment. Do you think this or other social media avenues could be useful in getting health messages to kids to encourage physical activity? And how do we meet these teens where they are?
That is a fabulous idea, and I completely agree that we should be exploring any options, whether it's electronic, using other type of technologies to engage kids to send the messages. In fact, we were just having a meeting this morning talking about using technologies and different type of gaming opportunities to help kids that might prefer to use that as a method for setting goals. So, for example, we did a little blog on the issue of using even electronic games like Pokemon to help kids get up, get moving, and cover that distance so that they're moving but setting little goals for themselves. In this other option where you're using text messages to get important messages across, I also think that's very important because of the prevalence of cell phone use in young people now. It's a go-to. It's a quick thing that they can look at for making sure they're staying on top of their activity goals, their tasks. Absolutely, I think it's a great idea. The motivational interviewing will be important for identifying what's important to the individual, and then based on that, you can customize your text information or electronic media to be able to address what that child's goal is. I agree.
Yeah. And we have a comment from a participant as well. That too often healthcare providers also enable pain catastrophizing behaviors. This is frustrating to see.
Yes,
But yeah,
absolutely. And thank you for identifying that as a problem because I agree with you. And that's part of what we try and study here is to help people get over that pain catastrophizing and that, yes, it is very hard to see people in pain. But at some point, we have to take that initiative and use the movement as an analgesic. And I don't hear that often said during therapy, but it's actually true. So physical movement can actually provide an analgesia as long as the person is willing to get over that initial hump of getting started with the movement and then it starts to feel better. So I agree. There is a lot of enablement with pain medications or pulling back and saying, no, you don't need to do that exercise because you're going to hurt yourself. We need to move away from that and more into being aggressive with physical activity.
great. Yeah, fantastic. I think see if they have any other comments coming in, but I think this was a great discussion and presentation and a lot of takeaways that we can all take with us, resources or some coaching tips, etc. So thank you, Heather, for that. That was fantastic. And
Thank
wanted to
you.
let you all know about next month's presentation. We'll be with Dr. Adam Good, and he will be discussing chronic low back pain in older adults, and that'll be on March 21st. So we just wanted to
Excellent.
plug that. But thank you again, Heather. And I think with that, we might sign off for today.
Okay. Thank you very